I would like to welcome you all to this webinar this morning, sponsored by the Global Alliance on War, Conflict, and Health. We have a wonderful presentation for you this morning with people from the Syrian Network for Human Rights. But before we start, I'd like to tell you a little bit about the Global Alliance. My name is Amy Hagopian. I'll be your host today. I'm professor at the University of Washington, and I'm a co-founder of the Global Alliance on War, Conflict, and Health. We're so glad you joined us this morning. Our alliance seeks to advance this field of scholarship and practice and provide leadership, promote equitable partnerships, and amplify the voices of those most affected by war and conflict. We formally launched with our webinar in the summer of 2022. We now have more than 100 member organizations from academia, humanitarian organizations, and journals. Let's see. We have a website where you can find information on how to join the Alliance, and we look forward to creating working groups on our platform where you can find collaborators on war and health projects, so stay tuned for that. This is the 7th in our webinar series. The first was on explosive events in urban areas. The second was on health systems in the context of the war in Ukraine. The third was on America's footprint in African wars. In November, we had a session on the long legacy of nuclear weapons production and testing and lingering health harms. Our 5th webinar was with Dr. Yara Assi, who has written a book called How War Kills. And then we covered what's happening in Sudan from a health systems point of view. And in May, we hosted a webinar on the emerging resistance health system in Myanmar. Those recordings are all or will soon be on the website. I'd like to thank 4 people who made today's webinar possible, in addition to the participants themselves. Becky Brown with Southampton University, who's on maternity leave, so not with us this morning. Elsara Badri, who works from Mozambique, and very importantly, Stephanie Endo, an MPH student at the George Washington University, who does the coordinating for these events. I'd also like to thank Samer Jabour, my co-chair. Our webinar series will take us to Armenia next on November 14th, so stay tuned for that. So this will be our agenda for today, which we will aim to keep to an hour. And just a few housekeeping items. We will ask our participants to stay muted with cameras off unless they are speaking. We will be recording this session. We will have a Q&A section, and so please enter your questions in the Q&A feature, and we will find your comments there and open it up for questions later. Let me now introduce our speakers. So for over 13 years, Fadel Abdul Ghani has made significant contributions to hundreds of reports and investigations chiefly concerned with analysis of gross human rights violations. He believes in the importance of documenting human rights violations, especially in Syria, and has repeatedly advocated for transitional justice and for holding all perpetrators of violations in the country accountable as essential prerequisites in establishing the foundations for democracy and respect for human rights there. Under his leadership, the Syrian Network for Human Rights has become an instrumental and dependable source of information for many UN organs, including the UN Human Rights Office. I can be showing you this, sorry. The Independent International Commission of Inquiry on the Syrian Arab Republic, and UNICEF, as well as the Organization for the Prohibition of Chemical Weapons. The organization's data are also used as a source by several leading international human rights organizations, including Human Rights Watch and Amnesty International. Many governments, including those of the US, Germany, France, the UK, the Netherlands, Canada, and Denmark, also regularly cite Syrian Network for Human Rights reports, as do numerous regional and global media outlets. Here's a map of Syria just to orient ourselves. There's a bunch of neighboring countries that are in play at the moment, so good to keep that in mind. Dr. Sparrow will be the interlocutor for Fadel this morning. She is an associate professor of global health at the School of Medicine at Mount Sinai in New York, where she teaches human rights and humanitarian aid in conflict. She's a board-certified physician in the US, the UK, and her native Australia, and received her master's degree in public health from Harvard. She combines the clinical skills of an experienced pediatrician with public health expertise acquired from working in many of the world's most devastating combat zones. Since 2013, Dr. Sparrow's focus has been on the humanitarian and human rights catastrophe in Syria, in addition to documenting the systemic targeting of doctors and hospitals and infectious disease outbreaks. She traveled to the Turkish border several times to train Syrian doctors in pediatric critical care. Dr. Sparrow has published widely on the weaponization of healthcare, a concept she developed from witnessing the Syrian regime's military strategy of using people's need for healthcare as a weapon against them by depriving them of it violently. In 2017, she was invited to join the Lancet Commission on Syria, Health in Syria as an expert researcher. Her research focus is on the nexus of human rights and health, especially how human rights abuses and violations of international humanitarian law in armed conflict situations harm population health, measuring mental and physical health outcomes. So I will turn it over to Dr. Abdul Ghani and let you take it away from here.
Thank you very much for our partner, the Global Alliance on War, Conflict, and Health, and for esteemed audiences for your time. So I wrote a paper. I used to document attacks on medical facilities and medical workers in Syria. But I want to test the correlation between the healthcare crisis and the displacement. So the case of targeted medical facilities in Syria. And this is the paper. I'll try to present the paper as quick as I can. It's a quite long paper, so I'll highlight four main points. The pattern and strategy of attack on healthcare facilities. This is the first point. The second, how attacks on healthcare facilities impact healthcare infrastructure and provision of healthcare services. Third, the link between attacks on healthcare facilities and population displacement. The final point, international legal framework and responses. So jumping in, we'll dive into the first point. The pattern and strategy of attacks on healthcare facilities. Attack on medical facilities have taken various forms. So in this paragraph, I try to make distinction between the early peaceful protest and how the Syrian dealing with that, with the injured protesters and activists, and then the stage after the peaceful protesters turn into internal armed conflict, and the opposition then gain control over large areas in Syria. So at the peaceful here, there is no choice but that those medical clinics being established in basement of residential building. When the areas large area became out of the regime control area, the Syrian regime developed its air forces to target medical facilities and their staff, using various munitions, including missiles, barrel bombs, cluster munition, and chemical weapons, particularly chlorine and sarin, against those medical facilities. As the conflict progresses and Russia launched its military intervention in September 2015, Russian forces targeting medical facilities with greater precision than the Syrian regime, using large guided missiles. They also employ double tap strategy. This strategy is initial attack, then followed by a second strike attacks to target the first responders and others who's rushing to help with rescue efforts. In addition to the direct attacks, medical facilities have been targeted in other indirect attack, particularly in area besieged by the Syrian regime, which took the form of restricting any access to the medical supply, equipment, banning the evacuation of the wounded, and targeting essential infrastructure support, healthcare delivery, such as energy and water systems. All of those attacks been well documented by the Commission of Inquiry and other international organizations such as Human Rights Watch, Amnesty International, Physicians for Human Rights, and also by our organization, which we build as a national organization. We build a database because we are following on daily basis what's going on in Syria, and we are able to document at least 897 attacks on medical facilities, not only by the Syrian regime and his allies. They are committed the majority of those attacks, but also by other parties. So if we distributed those attacks, the Syrian regime 561, that means 62% of all attacks. The Russian forces 209, ISIS 19 attacks, Hayat Tahrir al-Sham 2 attacks, the armed opposition group 15 attacks, the Syrian Democratic Forces, the Kurd forces, SDF 12 attack, and then the US-led international coalition forces 16 attacks. Also, we documented the killing of at least 900 medical personnel at the hand of the parties. And I distribute also these figures. So 657 by the Syrian regime, 96 by Russian and others. So moving ahead, here I want to highlight mainly 2 specific points. The fact that many medical facilities have been targeted multiple times over varying time interval further confirms the hypothesis of these facilities being deliberately targeted. In addition to these points, we have observed a clear conjunction between the military offensives carried out by the Syrian regime to capture territory and the targeting of medical facilities. I highlighted two main examples. The first one is the siege of Aleppo 2016 and how attacks on medical facilities conjunction with the military offensive, and also the Eastern Ghouta in 2018. On April 6, 2022, a report by the UN Headquarters Board of Inquiry, this a body established by the General Secretary, they confirmed in their report 4 attacks on medical facilities in Idlib. On June 24th, 2020, and so I link this the report outcome with what's happened later. The UN, the OCHA, received a notification by Russia that they would not be part of the deconfliction mechanism. And that we have sensed that this is a punishment for the outcome of the report, and Russia used to do that multiple times. I can here highlight, for example, after the join, this is after the mechanism established by the UN Security Council issued their 3rd report proving that the Syrian regime used the chemical weapons when the renewal for this mechanism, which is established in August 2015. This mechanism by the UN and the OPCW. The Russia punishment this mechanism using veto to ended their mission. So I think also here, this is a type of how the Russia is mentality in Syria. This and here I highlight this deconfliction mechanism established by OCHA in September 2014 to protect the medical facility, and that this mechanism share with the state the data on static humanitarian facilities locations. Actually, even before the Russian announcement, SNHR documented that 11 medical facilities which were part of the mechanism were targeted 20 times by Russia, by Syrian-Russian alliance. So, as I mentioned before, one medical facilities may be targeted multiple times, and that proved that this is a deliberated attack. Okay, all of those. Also we accused the Syrian regime and Russia because the Syrian regime has before the coordination of all hospitals, even those I'm talking about the official hospitals who's located outside of his control area, since those listed in the state institute, the Ministry of Health. So the regime has those coordination. So all of these forms that the Syrian regime and its allies targeted of medical facilities in Syria have been systematic and part of a strategy based on intelligence gathering to pinpoint the location of makeshift hospital or even private hospitals or mobile medical units with aim of bombing them. That's to say, these hospitals were target for the regime and its allies itself and were never collateral damage. The second point, how attacks on healthcare facilities impact healthcare infrastructure and the provision of healthcare services. Actually, here I face difficulties when I'm writing the paper because we have enormous impact on the attack on healthcare infrastructure. I tried my best to categorize them in three principal areas. The first one, severe shortage of medical personnel, supply and facilities. The systematic targeting of healthcare facilities and workers in Syria, coupled with displacement of healthcare workers fleeing violence and insecurity, has severely undermined the remaining healthcare system ability to respond to civil needs. This has particularly been the case in both opposition control area and among besieged populations, where access to medical care has been heavily obstructed by the Syrian regime and its allies. The resulting gaps in personal supplies and medical facilities have devastating consequences on the health of the Syrian population, contribution to increase the rate of preventable and treatable disease and deaths. According to WHO, an estimated 70% of healthcare workers have left the country since the beginning of the armed conflict, leaving significant gap of the availability of skilled medical professionals. Displacement was driven by various factors, including the direct targeting of healthcare workers by parties to the conflict, the destruction of medical facilities, and the deterioration of security and living conditions in conflict-affected areas. The destruction of pharmaceutical, also this, here I highlight that this destruction affected the medicine and distribute the distribution of supply chain have led to severe shortage of essential vaccine, medicine, medical equipment. This situation also exaggerated by the significant restriction by the Syrian regime. And here I highlight briefly that how is the Syrian regime also theft and loot the humanitarian aid. And this is also a huge topic. But I highlighted briefly, and here I refer to a solid report. Of course, there is a bunch of reference sources, but here I highlight the Human Rights Watch. I think it's the best report in this regard. So we documented here the targeted of medical facilities, and the impact have been particularly severe in opposition-held area. Geographically, I'm speaking. The second point here, the second category is the increased rate of diseases and death from treatable conditions. The inability to access effective and timely medical care means that many Syrians are unable to receive the necessary treatment for conditions that could otherwise be managed to cure. Consequently, Syria has been growing level of preventable illnesses, suffering, and death, especially among vulnerable populations such as women, children, elderly, and those with the chronic illnesses. The third point is re-emergence of infection diseases, including polio. The collapse of public healthcare infrastructure, including water and sanitation system, along with population displacement and challenges in delivering healthcare to conflict-affected area, created an environment conducive to the spread of infectious diseases. Among the most worried developments have been the re-emergence of vaccine-preventable diseases, particularly polio, which have been eradicated in Syria before the armed conflict. The re-emergence of these diseases poses significant public health threat, not only within Syria itself, but to the neighbor countries and globally. The last category, actually, the impact on vulnerable populations, such as women, children, and elderly. These groups often have specific healthcare needs that require specialized care and support, which has become insignificantly difficult to access in the context of armed conflict. As a result of this issue, many women has no access to adequate care, skilled midwives, increasing the risk of complications during pregnancy and childbirth. Actually, I'm trying to be very brief. There is a lot of explanation in each categories, but I'm just summarizing. So moving to the third point in this presentation, which is the main thesis of this paper, the link between the attacks on healthcare facilities and population displacement. Here I highlight 2 points. The first one is the direct impact of targeting medical facilities and their staff on displacement patterns. The second point is the challenges faced IDPs in accessing healthcare. So jumping to the first point. The direct impact of targeting medical facilities and their staff on displacement pattern. Indiscriminate aerial bombardment of residential neighborhoods have targeted a widespread state of fear and terror, causing residents who fear they may be killed or injured as a result to flee the targeted area. However, attacks on healthcare centers have a particular significant physiological effect on civilians. Such attacks send the message that in case of injury, no one will be able to treat or rescue the wounded. In this situation, even minor injuries, if left undertreated, can ultimately be fatal. Indeed, the targeting of healthcare facilities has created a vicious cycle of displacement, including the displacement of medical personnel themselves. Furthermore, attacks on healthcare facilities and medical staff embed the return of displaced people to their area of origin. NIRM's survey and interview, and I did also a lot with displaced Syrian and refugees even, not only IDPs, but also refugees, have confirmed that insecurity with respect to the healthcare sector was the primary reason behind their decision to flee. One of the clearest example, also the Eastern Aleppo and also Eastern Ghouta. But also here I highlight other example that the impact of healthcare destruction is not confined to the urban centers like Aleppo, rather than any small or rural area and small town across all Syria. So we can generalize this principle based on monitoring and based on what's happened after the attack. In many cases, the destruction of a single hospital or clinic have a ripple effect on the surrounding community, leading to the displacement of entire villages or even regions. For instance, I'm giving an example in North Idlib Governorate. The destruction of a hospital in the town of Kaframbil in 2016 resulted in the displacement of thousands of people, as that facilities were the only one providing medical care services in the local area. This is an example, but of course there is, I here rely on a great study and survey by SAMS, who is like confirmed that 77% of participants cited lack of access of healthcare as a major reason for leaving their homes. The second point is the challenges facing ITPs in accessing healthcare. So after they displaced, so this is essential actually, and this is the one of the goal of this paper. Of course, this is just the first version. It's need more work. Understanding the barriers that prevent ITPs from accessing adequate healthcare is crucial for developing targeted intervention and and policies to meet their needs and to protect their rights to health. The mass displacement of civilians, which is partly driven by targeting the healthcare infrastructure, has placed enormous pressure on host community and neighbors country, exacerbating existing social and economic challenges. So here I'm highlighting how this displacement affected the hosted community. So one of the primary challenges faced the ITP is the accessing healthcare is the destruction, as we mentioned before in this paper, because that lead to the shortage of medical staff and supplies. The second one is the second barriers here. The access is the lack of financial resources and the excessive cost of medical services. Many ITPs has lost their livelihoods, lost their neighborhoods, or left their livelihoods, and left the protection community, who is like they can rely on their uncle or relevant. There is like now they are scattered, so they are unable to maybe seek a loan or support from so they are not only displaced, lose their houses, but also they are scattered because displacement, they are waves is not moving to one direction, or they are unable to stay as they are before at the same area. So that, and here I also refer to the OCHA report. They conducted a survey in 2019, highlighted that 79% of the ITPs in Syria reported that excessive cost of medical services was a major barrier to accessing healthcare. The third challenges is the social and cultural barriers also reduce the ITP access to a significant degree, especially concerning mental and sexual and reproductive healthcare services. The social stigma and discrimination routinely, this discrimination associated with mental health condition, combined with a lack of available services and trained professionals, prevent many ITPs from seeking the care they need. This particular concern given the high spread of trauma, stress, anxiety among the ITP population, many of whom have expressed violence and lose in the addition of experience of displaced itself. So there is the difficulties, and I highlighted also some of the displacement difficulties itself, but those who's displaced, also they are facing already trauma and stress. They lose almost everything. Even some of them, they don't have their official ID, and also maybe some of them are victims. The fourth challenges is the security situation that also prevent and create significant challenges to the IDP in accessing healthcare in area where the conflict is still active. The risk of attacks on healthcare facilities and personnel, as well as the presence of the checkpoints and movement restriction, severely limited IDP's ability to access the healthcare services. ITP might also face harassment, discriminate, or violence from armed group or host communities, further jeopardizing their safety and well-being. Additionally, fears of arrest, detention, or forced conscription can prevent IDP, especially men and boys, from seeking healthcare or traveling to facilities controlled by other parties to the conflict. The last challenges here is the difficulties of accessing medical care in neighboring countries due to challenges related to the safe passage across border crossing. And many ITPs require special medical care or treatment. It's unavailable in their current location that they need to travel. However, this ability actually is often subjected to erratic political reality, and this decision beyond the control of the ITP or even the party of the conflict, the control area. This actually solely on the discretion of the neighbor states. The displacement, here I highlight briefly also the difficulties of the displacement itself, which is categorized as a long term. It has been observed that whenever regime forces regain control area, the majority of the origin resident of the area in question ought not to return to their area. Some areas, towns, and villages have been abandoned for over a decade, maybe another area 7 years, and it's. So this long displacement have severe consequences for healthcare sector, both for ITP and for host community. The mental health consequences for long-term displacement are also likely to be severe. Exposure to violence and stress of displacement can lead to elevated level of trauma, depression, anxiety, other mental health disorder among IDPs. The lack of access to mental health services and supply system exacerbate these challenges, leading to chronic and untreated mental health condition. Displacement also can have a significant long-term public health care consequences, particularly concerning infection diseases and diseases outbreaks. The collapse of healthcare system and the disruption of vaccination program can lead to the resurgence of vaccine preventable diseases as outlined above. Overcrowding, as well as the poor living condition in ITP camps and informal settlement, can also facilitate the spread of infectious diseases. Final point in this paper is the international legal framework and the responses. Due to the time limit, I don't want to highlight the international, the IHL and the applicable human rights law. This paragraph is a famous one. And also I highlighted key initiatives. I can say the UN Security Council Resolution 2286 and how is this resolution being built upon previous resolutions, such as 1265 1999 and 1894 2009 29. But rather than, I will jump to the final point in this paragraph, which is challenges, and here we have listened from Syria, challenges to accountable and challenges to accountability and the need for compliance mechanism and the recommendation for implementation obligations for implementing obligations. So the challenges to ensure compliance and accountability for attack on healthcare in Syria and other conflict-affected area highlight the urgent need to strengthen the legal protections and the enforcement mechanism. While the IHL and the international human rights law provided a clear framework for protection healthcare in armed conflict, their implementation and enforcement remain poor and inconsistent. In the Syrian conflict, the scale and systematic nature of attack on healthcare, coupled with the complex political security environment, have made it difficult to enforce IHL and bring those responsible for violation to justice. A fundamental challenges I want to highlight the challenges, and I have some recommendation, but I can move a little bit quickly. So the fundamental challenges is always the lack of political will. In spite of the well documented cases, there is no prosecution or other effort to ensure accountability for those responsible. The Security Council, which is paralyzed and unable to refer the cases in Syria in spite of crimes against humanity and war crimes to the ICC or establish ad hoc tribunal. The Russia and the China vetoes have prevented any referral. The challenges in ensuring compliance and accountability for attack healthcare actually is there is a little there is like a multiple players in Syria, and not only state but also non-state actor. That all of that make it little bit, or not little bit, maybe complicated to so in based on that, I have few recommendation to strengthening the enforcement mechanism. So the first one is that measures must be taken to improve monitoring and reporting of attacks on healthcare, as well as to employ targeting sanctions and other measures to pressure the perpetrator, Syrian regime, and other parties to the conflict to comply with their obligations. Second, there should be an emphasis on implementation and enforcement of existing IHL and human rights law provisions related to the protection of healthcare in conflict. This includes encouragement state to globally ratify and locally implementing relevant treaties such as the Geneva Convention and their additional protocol and the Rome status of the ICC. It's also involved engaging with armed groups to enhance their understanding and respect for the rules governing the protection of the healthcare in conflict, and ensuring their commitment to refraining from attacking healthcare facilities and personnel. The third recommendation here, the effort should be focused on strengthening local protection through domestic implementation of IHL and international human rights law. While most countries have ratified the Geneva Convention and other relevant treaties, many have not fully integrated these obligations into their domestic legal framework. This can create a gap in protection and accountability, as a national authority may lack the necessary laws and procedures to investigate and prosecute attacks on healthcare. I think this should be pursued diligently in Syria as a part of transitional justice effort. Now it cannot be. I think it's almost impossible because the perpetrator is governing the areas in Syria. The fourth recommendation is the necessary to address the root causes of the attack on healthcare in conflict zones, including the politicization and militarization of healthcare. And here a sensitive point, this includes promoting principle of neutrality and medical integrity, as well as the independence of the healthcare provides from political and military interferences. Fifth, there is a need to mobilize a greater political will and resources to protect healthcare in context of armed conflict in Syria. This includes advocating to prioritizing this issue on international agenda, including the UN Security Council, Human Rights Council, and other relevant platform. It's also involved mobilizing financial and technical support for implementing provisions of IHL and international human rights law related to the protection of healthcare. Finally, enhancing legal protection for healthcare workers and facilities, as well as mechanism for investigation and prosecution violation, is essential to ensure the safety and security of healthcare workers in conflict-affected environment and holding those responsible for attack on healthcare accountable, thereby deterring such attack in the future. Without affecting legal protection and accountability, attacks on healthcare, and that's what happened in Syria, will continue to undermine the provision of essential medical services, exacerbate the suffering of civilians population, and generate further displacement and perpetuate cycles of violence and instability. Addressing those challenges and recommendations requires a comprehensive, multi-phased approach that includes legal, political, and operational measures, as well as the engagement of a wide range of stakeholders, including states, international organizations, civil society, and affected communities. Thanks for listening.
Thank you so much. I would like to ask Annie Sparrow, who has joined us, and I did introduce you, Annie, to Dr. Sparrow to engage in the questioning. There was one formal question in the Q&A section, which you might notice, but I'm sure you have questions of your own. We can't hear you, though. You're not muted, so there's something about your audio setting, something with your microphone. Okay, why don't I ask the question in the Q&A while you sort that? So the question comes from Mohammed Al-Khattab, who asks, in terms of geographical distributions of attacks, can you please comment on differences between the northwest and the northeast of Syria, and also the coping mechanisms, including referral to nearby countries such as Turkey in the case of the northwest, which might imply these attacks were pressuring the Turkish health system as well. And it might help to show the map again, so I'm going to bring that up.
Are you able to hear me now?
Yes, we can.
You can? Okay, great.
But maybe we'll have him answer the question that was just posed from the Q&A.
Absolutely. And then I have a
West.
Yeah, thank you for the question. And indeed, it's a vital one. And I little bit highlighted that the most affected area is the area which is out of the regime control area by deliberate targeting, especially by air forces. So the northwest Syria is where is the most documented incident took place. And that and also the northwest Syria contained the intensive population, because those I highlight, for example, eastern Aleppo or eastern Ghouta, or those areas, when they displaced, they moved to the out of the regime control area, and they stayed, they didn't back. So so we faced here triple difficulties. First of all, the vast majority being targeted of the medical facilities several times, the intensive displaced population, and also the border being closed. And I agree that the injured, the border should be opened in front of the injured people, which is not. Some of them they waited for hours, and that, as all doctors know, they affect their injured, and maybe they caused them their life. I don't know how we can pressure more the neighbor countries, but here we are talking about Turkey mainly. This is the only country which they have border on northwest Syria. About the northeast, also the situation is not much better, but it's being targeted less than the northwest, the medical facilities there. But also they are facing a lot of similar difficulties and the challenges. The crossing border between northeast and Iraq easier than moving the injured from northwest to Turkey. So I think that we need to highlight this correlation between and the paper has for sure has limitation. Maybe this is one of them.
Dr. Sparrow?
Oh, thank you so much, and my apologies for my own glitches. And Fadel, I think you've raised these extraordinary points in a very constructive and helpful manner to think how we must now address. Syria has, with the help of Assad, with the help of Putin, has really piloted how to do this very, very effectively. And in fact, Syria leads the world in forced displacement, because there are, as you know, 7.5 million refugees and another 7.2 or 3 internally forced displacement. And when we talk about not being able to go home, we've seen the rise in asylum seekers of Syrians who've lived around in Europe for years and now have given up on the hope of going back. And so one of these, I mean, I think Syria absolutely defines these characteristics of modern war. I mean, Putin has done this very well even before Syria and adopted the same tactics first day of Ukraine. And I think that, you know, one of the hardest issues for many of us who are not directly and deeply involved is to understand what it really looks like or feels like, and the intent, which is so malign and so cruel and has this cascading effect, as you've described. And, you know, in Syria, in the first week when we talk about the onset of violence, March 22nd, 2011, was my first experience of the first attack, which was on a mosque serving as a field hospital in Daraa. And there was a student protest outside holding olive branches. And then the mosque was attacked with a lot of Iranian soldiers. And the mosque put out a call for help from the hospital. And one of the surgeons, Dr. Ali, put a team together of paramedics, so an ambulance driver, a nurse, and himself. They came to the mosque. They were able to receive just one single student. There were 3 or 4 other survivors, but everyone else had been killed already, including the patients and the doctors inside the hospital. And on the return to the hospital, they were ambushed, the ambulance driver killed, and the Iranian forces opened up the back doors of the ambulance and then shot everyone. And the doctor died because he lay over the patient, and so the patient was the only one to actually survive. And this was in the very, very beginning. So we can see that even well before we call this an armed conflict, because Syria was not described as an armed conflict until July 2012, we're already seeing this intentional way to target that is so very, very effective. Right from the beginning, you know, you couldn't access blood bags anymore as a medic. And, you know, how do we actually give blood, whether it's to a mother who needs blood postpartum, post-delivery, or to a shock patient or a trauma patient, or somebody with, so many blood diseases. And I think one of the problems we've had over the last 10 years in uniting people around this issue is that we don't all define attacks against healthcare the same way. And I think for Syria, it's absolutely 100% clear. And we also see this in Ukraine, that the impact on forced displacement is massive. It's both a primary and a secondary driver of forced displacement. And that makes a lot of sense. I mean, the government immediately creates a need for healthcare by bombing civilians, and then at the same time simultaneously attacks the hospitals. So then where do you go? And if you have a chronic disease, whether it's diabetes or a heart condition or cancer therapy or kidney failure, well, then you need to leave, because you're not going to be able to actually get help. so it's an incredibly effective way of forcing people from their places. And it's a policy that I would call both, it was scorching the earth when you're destroying a person's home or village, and insulting it as well, right? Because you're destroying all the infrastructure and how you could deliver health. And quite often the land is then taken over by a different clan altogether, which makes it impossible. And another dimension that I think is a global issue that we don't fully appreciate is that the malignancy behind what is allowed in and what isn't allowed in. So in Eastern Ghouta, which was it's only 10 miles from Damascus, very civilized area, and used to have 1 million people before the war. And fairly early on, it was quite clear by the end of 2012 that they must start building tunnels to be able to have access.
Mhm.
And they could do that because they were close to Damascus, and it was a sort of rural area, semi-rural, so you can't do that in Aleppo, but you could do that. And so they did this, and they arranged, for how food to come in and medicines and evacuations. And in the end, there were 4 tunnels that were able to be used to,
Mhm.
and they were Ghouta's lifelines for years and years. And we could see how inadequate the UN convoys were, because the Syrian Ministry of Health, I thought he had said Mystery of Health, and I thought that's a good way to think about it. It's a mystery
Yes,
of health,
indeed.
because, but they have a very clear list of items that are not allowed. The antibiotics, anything to do with infection control, no sterilization, no chlorine, no bleach, no surgical items. So there's no way to sterilize surgical items. Then how can you do surgery? But the 2 issues which I found particularly so malign was to actually take out the umbilical clips that we use when we deliver babies. We put it on the umbilical cord, and that is their only purpose. You can't use umbilical clips for anything else. And of course, but if we don't do that, then there's a much greater risk of sepsis and of dying. And so if you don't use an umbilical clip, then you have to use a special thread of surgical thread to tie it off properly. And so it's not as if, it's a very clear calculus of what is allowed in. Let in the light shampoo. I mean, the mice are not going to kill us, but we won't let in any antibiotics or anything that will. It's a very sort of clear way of making people suffer, and of course it's a very effective. So this is where but across the realm, we think about healthcare attacks as a kind of visceral bombing of a hospital or an ambulance, and we don't really fully appreciate that there is the items that aren't allowed in, the siege, and that includes things like to prevent waterborne diseases. When you destroy the water sources, if you don't allow in chlorine, well, that's what then we see this massive number of infectious diseases. I mean, we rely on chlorine the world over in order to keep our drinking water safe. It has a huge role in controlling polio, and a major role in public health. So
yes, Dr. Sparrow, I'm so glad you were able to add these thoughts to Fadel's presentation. And I think one of the things that all of us who have observed this conflict and the health workers in the context of this conflict is how adaptive and innovative and resourceful people have been. And I think one of the important concepts you've introduced here today is that the attacks on healthcare have multiple purposes, but one of them is to actually drive displaced people and to drive people out of the places where the regime no longer wants them to be present. That brings us to the end of our webinar today. I'm so grateful to everyone for participating. Look for the November 14th webinar on the situation in Armenia and Nagorno-Karabakh, and look for the recording of this webinar on our website. And thank you very much. Let's all go out in the world and make a little less war. Thank you, everyone. Bye-bye.
Thank you. Have a lovely day. Thank you.
Thank you, Fadel.